Okay. Please continue, people are saying.
What are they saying? They want to go? Oh, wow.
Yeah, very
Okay, so it's malignant. So it's melanocytic, big irregular blotch, big regression area. Here we have peppering, just to talk about the criteria. Good. So blue, let's just say benign or malignant. Let's go because people want to go. So is this benign or malignant?
Okay, we'll launch the poll.
Launch the poll.
Vote.
Vote. Got a couple of great cases, so don't go away. One very important case coming up.
This one's also quite clear.
Good. God, you. Okay, good. So this is a spitzoid melanoma. So there's a bluish white veil color. There's asymmetry color and structure. It's melanocytic because there are some brown globules. Big irregular blotch. And it's spitzoid to me because it's dots and globules, but they're irregular or streaks at the periphery, but they're not around the whole lesion. So this is a spitzoid pattern that turned out to be a spitzoid melanoma. This one we got to do. Benign or malignant on the, this was on the trunk. This one is a must. This is very important. So we're going to vote on this. I know that the time is up, but let's vote.
Don't worry about it. People are happy to do this.
Okay, good. I'm happy. This is fun. This case is really, what is it? I don't know, but it's a little pink thing, pinkish brown. Benign or malignant?
We got 2/3 voted.
Good.
This one isn't as clear.
Okay, good. That's pretty good. Well, I don't know. So I don't know if they're right or wrong. So what do you think? Benign or malignant? Let's vote on this. Let's vote on this. Benign or malignant?
Okay, 3, 2, 1. That's it. Time's up. Share this.
Ooh, wow. Wow. Okay, so this is, oh, here's a saying for me. If you see pink, if there's pink, stop and think. Whenever you see a pink lesion, think, because if it's pink, it might stink. So those are two sayings to raise the red flag when you see a pink lesion. So this is a melanoma. There's different shades of pink color. There's white color of regression. There's crystalline structures. There's some brown color and some blue color. So that's very good, but pink lesions are difficult. So clinically, is this benign or malignant? I didn't put this into vote, but just think in your own minds, is this benign or malignant? It's a pink lesion. I found that on the hairy chest of a patient. I had to cut the hair away because I couldn't see it. So I'm thinking to myself, is he lucky, or is this going to be his lucky day or unlucky day? So there's crystalline structures, there's polymorphous vessels, there's a milky red area. This has all the criteria of being a melanotic melanoma. Comma vessels, I mean, this is really, 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 really bad. But it turned out to be a lichen planus keratosis. So don't get scared, but pink lesions scare me. When I see a pink lesion can be melanocytic, non-melanocytic, benign, malignant, or inflammatory. And dermoscopy is not as helpful with pink lesions as it is with the pigmented, the melanocytic lesions. So a few more of the foot, benign or malignant. Let's just go to the dermoscopy. So let's vote on this, benign or malignant. I think there's 2 more cases and we're done. Yeah, pink lesions are pretty scary for me. See a lot of pink lesions. Benign, whoops, sorry. So they're voting.
They're voting. All right. 3, 2, 1. That's it. Let's share it.
Wow, my God, the world is smart. They didn't need this lecture, I don't think. So here we have a parallel pattern, but you really can't tell if it's a ridge or furrow. Here, parallel pattern is suggestive that it might be a ridge. But there's so much more going on. There's asymmetry of color and structure. There's some white color, maybe a white network, irregular dots and globules. So there's a lot going on here. It's not a benign pattern you need to do biopsy. So let's do this. Let's vote on this, benign or malignant. Benign or malignant. Benign or malignant. We're voting, right?
Yeah, people are voting.
Good.
Pretty clear. I'll stop this early.
What? Okay.
It's here.
So it's melanoma. So there's blue color, there's white color, there's pink color, irregular globules, there's black. I mean, this is a mess. And here we have a nice example of aquasyringium. So it's not blood because the guy was hiking in the Alps. Okay, I think this might be the final case. This is a young girl with a nail. So benign or malignant, we'll vote since we're already over the time. We're almost finished. The world is smart. I'm very impressed. I'm happy. Congratulations, world. So benign or malignant, it's a young girl, so it's not old.
This is more tricky.
Life is tricky, especially these days. So we're voting. Let's see what people say. But you need to look at it with dermoscopy, so that's important. It's not an easy place to, okay, everyone's not sure, but you're going to take out your dermatoscopes or your DermLites, excuse me, and now is it benign or malignant? Let's vote on this. Benign or malignant. So is this a good melanoma or a bad melanoma?
Okay, 3, 2, 1.
Okay, good. So this is a melanoma. These are irregular bands. They're different thicknesses and colors. There's loss of parallelism here. There's no lines here. And it's not really common to see irregular dots and globules in the nail. So I'm going to leave you with this little thought. If in doubt, cut it out. Even the most experienced dermoscopist doesn't always know what's going on. So if you have to think too much about what's going on, do a biopsy. And finally, I want to let you know that Dr. Stoltz and I have the book out from McGraw-Hill called Dermoscopy Criteria Review. And I think Dr. Stoltz and his group is on the audience. I want to say hello in Munich, Germany. And I think we're going to be giving a few of these books away. So Dermoscopy Criteria Review, it's a relatively new book. And that's Florida. And we're done. We're done. Thank you.
Perfect. Thank you, Robert. Now we will take some questions. So we have a few questions, and I will try to combine some of them. So first one is, what actually causes the white network? histologically?
I mean, I don't think it's really well worked out. I think it's just hypopigmented reedy ridges surrounding nests of melanocytes. But I've never read a good description of what it is. But that's what I would say would be my definition of what causes that.
Okay, and
I think
then
if you go to the Dermoscopy thing in the International Dermoscopy Society, they kind of say that. But I don't think it's been well studied.
and the difference between of blue-gray and blue-gray veil and white regression areas, and are they related to crystalline structures?
No, crystalline structures are some variation of scarring, and the bony white color of regression are scarring, and the bluish white veil has nothing to do with scarring. It's just orthokeratosis and pigment at different levels, so they're different. They're different. So it's a good question. I said, why can you see scarring without you don't need polarized dermoscopy to see scarring, but you need it to see the crystalline structure. It might have to do with the way they're oriented, the lines of the crystalline structures. That's my best answer.
Good, thank you. And then we have a question about vessels. So how do we differentiate between surrounding telangiectasia and arborizing blood vessels in a BCC? And
Okay, that's a good question. So if you have a lesion that you're looking at, let's say a nodule on the chest in an old person, and you see arborizing vessels, they're going to be in the lesion. They're not going to be surrounding the lesion. So they're within the lesion, as opposed to telangiectasias in just sun-damaged skin. They're going to be on the skin. They could be over the lesion and outside of the lesion. So typically it would be something that you see inside of the lesion.
okay, and related serpentine and arborizing vessels, what's the difference?
Serpentine and arborizing. So arborizing vessels are branching. So they're different calibers of in-focus branching vessels, as opposed to serpentine, where they're not branching. They're just like little irregular, squiggly kind of, they look like little snakes. So they're not branching. They're just linear, irregular, and shaped like a little snake. So they're not branching and they're not arborizing, or they're not branching.
Okay, and then regarding pigmentation and regression, how do we differentiate between regression in a nevus versus in a melanoma?
Regression is regression. There's no difference.
Okay.
Just if you see bony white, I think it's very unusual to see regression in just a regular nevus. You could see it in a dysplastic mole if it was traumatized, but regression is regression. And that brings up a good point. When you're looking at a lesion dermoscopy, you want to analyze all the criteria. You don't want to just look at one criteria and then jump to conclusions. So regression is regression wherever you see it. It's bony white, milky white, irregular color. So you can't tell. You have to see what else is going on to see, is it a benign mole? Is it irritated mole? Is it a melanoma? But the criteria is the criteria.
Okay, and then there's a question. The question is basically follicular pigmentation versus pseudo network. How would you take that question?
So follicular pigmentation are roundish irregular structures. They're caused by invagination of the epidermis, and they're filled with sebum. They could be pigmented or non-pigment. And the pseudo network, those are follicular openings, which are roundish structures also that come into areas of pigment. So I would say the pseudo network would be more regular, the roundish structures, and the pseudo follicular openings are more irregular. But definitely there are times when you can't tell, is it a milia-like cyst or a pseudo follicular opening? So you're not always going to tell the difference, and that's where the dermoscopic differential diagnosis comes in. Things are not always going to be clear, and you just have to do your best to figure out what's going on. And also very important to analyze everything before you come up with your diagnosis.
Okay. One more vessel question in a lesion with lacuna vessels. Is the presence of a vessel within the lacuna a clue to melanoma?
Say that again.
So within a lesion that has lacuna vessels, is the
Yes.
presence of a vessel, is that a clue to melanoma?
I would say no. But I can tell you, I have seen, okay, be aware that there are melanomas that can look like hemangiomas. There are melanomas that look like basal cell, that can look like seborrheic keratosis. I've seen melanoma and metastatic melanoma that looks like they have well demarcated vascular spaces that you would call lacuna. So it's just, if they're reddish, then, I mean, you're not going to see really that in melanoma, but lacuna-like vessel structures, well demarcated, if they're brownish, don't be fooled to think they're lacuna. So I would say lacuna, if they're well-developed vascular spaces. I don't actually think I've ever seen that in melanoma, so, but everything is possible. But that's not the typical vessel. We don't consider that the vessel that you would see in the polymorphous vessels that you would see with melanoma. So I would say just be aware that they're hemangioma-like melanomas, so don't confuse that with hemangioma.
Okay, great. Then we have a question about blue-white structures. They want, someone wants to differentiate the blue-white veil of a BCC from that of a blue nevus or hemangioma.
The bluish-white veil, I don't really think of the bluish-white veil in a basal cell carcinoma, so that's not something I would think. What was the second part of that question?
Yeah, basically that's the differentiating the blue-white veil, if there is one in a BCC, from the blue-white structures in a blue nevus or hemangioma.
No, I mean, I don't think, yeah, that's not a question.
Okay. And then if you can't do a biopsy question, if you can't do an excisional, what would you consider, or how do you go about finding the best place to do a biopsy in a suspicious melanocytic lesion?
Okay, so one of the colleagues sent in a case. I guess we're not going to see it, but I thought about the answer. It was a young pregnant woman that had a pigmented lesion on her lower leg, it looked like, and the doctor thought it was an angiokeratoma. There were well demarcated vascular spaces and a hyperkeratosis. So I agree with her diagnosis, but the lady was pregnant, 50 years old, and she didn't, I guess she was concerned to have an excision. So I was just thinking, if I saw that patient in my office, I would not hesitate to do a shaved excision. I wouldn't do a big scalpel stitch excision. I would just do a shave and a cauterizer. You could just do it in 2 minutes, and the patient, I think, would be very happy. You get the job done. So the question for you is, okay.
Okay.
If you have a large lesion, that question usually goes for something like on the face. So you have a large pigmented lesion on the face. You can't do a big cutting. You can't remove the whole thing. So you look for the area where there's the melanoma specific criteria. You look for the area with the asymmetrical follicular pigmentation. You look for the circle within the circle. And you're not going to see it everywhere. You can even see criteria of a lentigo in a melanoma. So what you do in the larger lesions is I look for the area of high risk criteria, and then I do 1 or 2 biopsies, usually 1. And if there's not a good dermoscopic pathologic correlation, in other words, I think it's melanoma, but it doesn't come back as melanoma, I would talk to the pathologist or do another biopsy. But you look for where the high risk criteria is. You don't always have to remove the whole lesion if it's a big spot.
Okay, and then related biopsy question regarding lentigo. This person is saying some have uniform brown pigment, but perifollicular pigmentation, usually brown.
Yes.
Would you biopsy?
Any asymmetrical follicular pigmentation, light brown, dark brown, black or gray, barely visible, I would do a biopsy. And I do that routinely, and most of the time it turns out to be high risk. So if you see it in any form, I recommend to do a biopsy in that spot. You can mark it with a little pen, and that, so you will get it. Use dermoscopy to find those spots, obviously.
Mm-hmm. And a biopsy in a regression area is not a good idea. Is that true?
Yeah, that's true because it might just be scar. Yeah, you could miss the pathology, of course.
Okay. Then we have more coming in, but we'll maybe do two more. How about differentiating AK from in situ SCC?
That goes back to, I mean, pigmented, you can't, I mean, last week the talk of it, scaly, not scaly. You know, I just think if you see asymmetrical brown spot on the face, could be lentigo, could be pigment actinic, could be Bowen's, could be lentigo malignant. For me, and I see a lot of it, I think it all looks the same. I don't think you can tell the difference. If you see any of the criteria, you biopsy it. And I can't tell the difference. That's my experience.
Okay. And before you put your DermLite on the skin, do you put any kind of liquid, oil or gel? And if so, like under what circumstances do you do it?
So if you have a young person with not dry skin, I don't do that. But if you have an older person with dry skin, any lesion is going to look better without dry scaly skin. So I would just swipe it with alcohol, with a little alcohol wipe to look at it. If you want to look at vessels, if you want to get a really good look at vessels, you might put hand cleaning gel on it and not a lot of pressure. So I think just a general principle, dry skin is, you don't see as good with dry skin. So you want to get rid of dry skin. Not a lot of pressure or hand cleaning gel to get a better look at vessels, in my experience. And not a lot of pressure because you can just blanch them out.
Okay, excellent. We're going to wrap this up. So thanks everyone for participating. I hope you liked it. This is our 4th episode, so we hope to have you back next time. So after you leave, you'll have a chance to leave some feedback for us. We'd really appreciate it. And this time, when you complete that feedback form, you'll be eligible to win one of 5 copies of Robert's book. So it's actually definitely going to make it worth your while to complete that feedback. So
I want to say one thing, a final remark. Just to the world, be safe out there and just take all the precautions you can, and hopefully we'll get through this terrible virus thing. Just be careful when you're seeing patients and everything you do.
Yeah, I couldn't agree more. So for Robert and the entire 3Gen team, thank you so much for watching, taking the time to be with us. So depending on where you are, have a great day, have a great evening, a great night, and definitely have a great weekend. Be safe, use your superpowers, and stay healthy. So thank you so much.